So now we are in leukemia. So there are two types of leukemia, acute leukemia and chronic leukemia. Sa acute leukemia, just like any acute conditions, pag sinabing acute, sudden onset and rapid progression unless treated and is characterized by the presence of blast cells in peripheral blood and bone marrow. So sinasabi dito na sa acute leukemia, this is a sudden onset of disease or disorder, and this is characterized by STTL or shift to the left. So anong meron kapag shift to the left? Appearance of young immature cells or blast cells. So kapag sinabing chronic matagal na. Gradual onset and slow progression characterized by the presence of more mature cells. Opposite to acute leukemia is the chronic leukemia, merong shift to the right. Kung sa shift to the left na nasa acute leukemia, merong appearance of young or immature blast cells in peripheral blood and bone marrow. Sa shift to the right na nakikita sa chronic leukemia, merong appearance of more mature cells in peripheral blood and bone marrow. Sa acute leukemia, nakakakita tayo ng myelocyte, metamyelocyte. Sa chronic leukemia, ang nakikita lang natin yung mga mature cells, kung granulocytes, kung lymphocytes, mature lymphocytes. Okay? So before we proceed dito, wala akong notes masyado sa leukemia kasi this is how I categorize leukemia. First, okay, so kanina, during recitation, tinanong ko sa inyo ano yung normal ME ratio. So the normal ME ratio is 3:1. In cases of leukemia, nagkakaroon ng, ang ME ratio is 10:1. 10:1, hindi affected ang RBCs, kaya merong normocytic, normochromic appearance of red blood cells. Anong nangyayari sa leukemia? Okay? For clarification, ang anemia ng RBC, meaning merong decreased RBC and hemoglobin na nagkakos ng anemia. Ang WBC, hindi yun equivalent sa leukemia. Okay? Ang anemia, walang RBC. Sa leukemia, opposite ang meaning. Merong overproduction. Overproduction of various types of immature and mature WBCs. And there are two types of leukemia. It is either myelogenous or lymphocytic. So sa leukemia, so sabi natin merong lymphocytic and myelogenous. Sa lymphocytic, there are two types, lagi, acute and chronic. Ganun din yung myelogenous, acute or chronic. So unahin muna natin si lymphocytic leukemia. Again, ang leukemia, there are two types, myelogenous in origin or lymphocytic in origin. So kapag sinabing lymphocytic leukemia, ang overproduction of cells pertains to lymphocytic series or yung lymphocytic cells. Kapag myelogenous leukemia, there is an overproduction of myelogenous cells, granulocytes, and monocytes. So kapag lymphocytic lymphocytes, myelocytic or myelogenous granulocytes, and monocytes. So lymphocytic is either acute or chronic. Ang acute lymphocytic leukemia or ALL is categorized into L1, L2, and L3. So pag sinabing ALL, acute lymphocytic leukemia, we have L1, L2, and L3. Pag sinabing CLL, chronic lymphocytic leukemia, ano yung cell na nag-a-appear dito? Smudge cell or Rider cell. Next, myelogenous leukemia or myelocytic leukemia. It's just the same, pero gamitin ko si myelocytic. Si myelocytic leukemia, ang dating pangalan nito, you will not see this in Rodax but in Turgeon instead. When it comes to leukemia, mas ginagamit ko yung Turgeon kasi sobrang advanced ni Rodax. More on genetic, so hindi na maintindihan. So most of professors, luma pa rin ang references when it comes to leukemia. So ang myelocytic, isa sa term nito is non-lymphocytic. So meron tayong acute myelocytic leukemia or chronic lymphocytic leukemia. AML or acute myelocytic leukemia, CML or chronic myelocytic leukemia. Other terms nito is CNLL, ANLL, acute non-lymphocytic leukemia, yun nga yung lumang term, or CNLL, chronic non-lymphocytic leukemia. Baka kasi ma-encounter nyo. Okay? So we have acute myelocytic leukemia. Dito papasok yung FAB. FAB, M0 to M7. Chronic myelocytic leukemia, ito yung problem sa genes. Chromosome translocation between 9-22. And ang involved na gene dito is yung tinatawag na BCR-ABL. So yan yung categories of leukemia. Ano yung origin? Ititrace kasi lymphocytic ba siya or myelocytic. Ang next na ide-determine acute ba siya or chronic. How do we differentiate acute and chronic? Titignan natin yung appearance of cells. Kapag shift to the left, acute yun. Anong meron sa acute? Appearance of immature cells. Chronic, shift to the right of WBC, merong appearance of more mature cells. Idagdag ko na lang din dito, sa lymphocytic leukemia, this is negative for MPO or myeloperoxidase and Sudan black SBB. Sudan. Ano kung ito isang B? Sudan black. Ano itong SBB? Kayo na bahala. Basta SBB stain. Mamaya, baka maalala ko. While si myelocytic leukemia, Sudan black. Ito lang makaget over. Ano ba itong SBB? Sabihin niyo na nga. Sudan black blue. Ano itong SBB, guys? Histopath. Sudan black B. Sudan black B. Ang tama ko. Sudan black B stain. Sa myelocytic, this is positive for MPO and Sudan black B stain. Ngayon, ano itong stain na to? Before, to diagnose leukemia, ang ginagamit natin is cytochemical testing or cytochemical stain to differentiate leukemia. Before yon. Pero nung nagkaroon na ng advancement, ang ginagamit na natin mostly is flow cytometry. Sa flow cytometry kasi, dinedetect na noon yung mga surface expressions, genetical expression. Etong leukemia, mostly, this is due to disorders arising from genes or chromosomes. So, hindi na namin ituturo yun. So, maski ako hindi ko alam yun. Nakakabaliw yun. Sobrang daming gene involved. So, dito tayo sa lumang version ng leukemia. So, cytochemical stain ang ginagamit to differentiate lymphocytic from myelocytic leukemia. So, kapag lymphocytic, that is negative for MPO and Sudan black B. Bakit negative for MPO ang lymphocytic? Kasi ang MPO, nakikita lang to sa primary granules of granulocytes and monocytes. Okay, so unahin natin si ALL, L1, L2, L3. Si L1, small, homogeneous, ito yung tinatawag na childhood ALL. Si L2, this is large and heterogeneous. Ito yung tinatawag na adult ALL. L3, large and homogeneous Burkitt's type. Ano tong small, homogeneous, large, heterogeneous, large, homogeneous? Ibig sabihin, yung appearance of lymphocytes are small and homogeneous. Iisa lang yung type of population. Sa L2, yung appearance of lymphocytes are large and heterogeneous, mixed population. L3 is large and homogeneous, large lymphocytes with homogeneous population. To better differentiate the three, gawa tayong table. L1, L2, L3. So let's differentiate L1, L2, L3. Number one, we have the immune markers. Ang immunological or immune markers na ginagamit sa L1 is yung KALA, CD10, yung tinatawag na TDT, CD19, and CD20. Sa L2, ang ginagamit na immune markers, TDT lang. Sa L3, CD19, 20, 22, 24. Next, cytochemical stain na to, PAS, periodic acid shift. Ang L1, PAS, positive, same with L2, except L3, which is PAS, negative. Next cytochemical stain used is oil red O. Baliktad naman ang result. L1 and L2 is negative, while L3 is positive. Lastly, i-expound natin yung appearance of cell. Ano yung appearance of blast cells? Since acute to, merong appearance of immature cells. So we have the blast cells. Sa L1, madaming blast cells and then small. Sa L2, konti yung blast cells. Kaya nga homogeneous kasi madaming blast cells. Sa L2, heterogeneous kasi kakaunti lang yung blast cells, so meron pa ring appearance of normal cells. So heterogeneous population, few, and these immature cells are large. Then yung L3, yan, large and homogeneous. It is otherwise known as Burkitt's. Meron pa itong isang ginagamit na isa, idagdag ko na. Yung methyl green pyramine. So this is negative, negative, positive. Okay? So yun na yung acute lymphocytic leukemia. Next, we have the chronic lymphocytic leukemia. So as mentioned earlier, si chronic lymphocytic leukemia, ang nakikitang cell dyan is smudge cell and Reiter cell. So wala naman na tayong other idadagdag dito aside sa dito na lang. CLL. So nakakakita tayo ng smudge cells, Reiter cells. Pag sinabing Reiter cells, clover leaf-like nucleus. Meron tong translocation between chromosome 11 and 14. Common feature niya is lymphadenopathy. Lymphadenopathy. Yun lang, wala na masyado sa chronic cell. Next, let's proceed sa myelocytic leukemia, acute or chronic. Unahin na natin si acute. So may kita nyo dyan, ANLL or AML, acute non-lymphocytic leukemia, or acute myelocytic leukemia, or acute myelogenous leukemia. All of those are the same. So sa FAB classification, we have M0 to M7. Ito yung table na yun. Excuse me. So we have M0 to M7. Ito yung FAB classification of acute myelogenous leukemia. The key here is to distinguish yung percentage of blast cells. So we have M0, acute myeloblastic leukemia, minimally differentiated, M1 with no maturation, M2 with maturation, M3 promyelocytic leukemia, M4 myelomonocytic leukemia, M4 EO with eosinophilia, M5 is monoblastic, M6 is erythroleukemia, M7 is megakaryocytic leukemia. Next, dito tayo sa morphology. Si M1, si M0, M1, M2, lista natin. Yung FAB, classification na may greater than 30% of blast cells, we have M0, M1, M2, M1, 2, 3, 4, M0, 2, M5. Ano pa yung mga tatandaan sa table na to? Hahanapin kapag mga ganitong overwhelming information, hahanapin yung similarities and differences. Next, appearance of our rods. So as discussed earlier, ang our rods, merong defect sa granules. Ang our rods, merong fused primary granules. Ang appearance nito is red, fused primary granules. Ang appearance nito is red rod shape. Saan nakikita si our rods? So ang palatandaan ko dyan, si our rods, since fused primary granules siya, nakikita siya sa stage kung saan nag-appear si our rods, which is sa pro-myelocyte. But, sabi ko nga kanina, debatable to kasi si Rodak, sinasabi niya, myeloblast pala, may appearance na of primary granules. Si Turgeon, sinasabi niya na pro-myelocyte yung start ng appearance of primary granules. Pero if you're gonna look at this table, yung myeloblastic, it can be positive or negative pa for our rods. Itong myeloblastic with maturation, meron ng appearance of our rods. Pero, yung strongly positive na our rods, or yung definitive na makakakita tayo ng our rods, here is sa M3, which is pro-myelocytic leukemia, prominent primary granules. So, plus or positive sa our rods. Hindi lang our rods, merong fagot cells. Again, kapag yung cell, madaming our rods, ang tawag doon is fagot cells. So, nakikita ang our rods, si M1 can be positive or negative. Si M2, positive. Si M3, strongly positive. And so on. Okay? Lahat na may our rods kasi syempre yan ay developmental stages. So after promyelocytes, we have myelomonocytes. So expect na makikita nyo na yung our rods all throughout. All throughout until M6. So si M2, M2, M4, M5, M6 is positive for our rods. Next. Next, ito another differences nila. Si M4 is monocytic in origin. So kay M4, merong 20% monocytes, pati kay M4 with eosinophilia. While si monoblastic na M5, greater than 80% ang monocytes. Ilista ulit natin. Greater than 20% ang monocytes. This is M4. M4 with eosinophilia, yun na yun, same. While greater than 80% ang monocytes, this is M5. M6 is erythroleukemia, so makakakita tayo ng 50%, greater than 50% presence of erythroblast. Erythroblast yan. M7 is megakaryocytic, so ganun din, makakakita tayo ng megakaryoblast. So yan, ganyan aralin yan. Plus, itong mga cytochemical stain. Always remember na ang myelocytic is positive sa MPO and SBB. So i-trace natin nasaan ang mga myelocytic. So myeloblastic wala pa kasi blast cells pa yan. No granules, walang primary granules, so wala pang MPO. So negative pa for MPO. Kailan nag-a-appear ang MPO? Appearance of granules. So pag may nakita na kayong granules, matik magpa-positive na yan sa MPO. So MPO, SBB is positive for myelogenous in origin. Ito yung next na i-discuss natin. Specific and non-specific. CPAS sa M6, PAS positive due to the presence of erythroblast or otherwise known as normal blast. Okay. Okay, let's move forward sa cytochemical stain. Cytochemical stain for leukemia. So generally we have MPO, SBB, and yung naphtol, ASD, chloroacetate. Chloroacetate. MPO, SBB, naphtol, chloroacetate. Itong tatlong to, ginagamit to, this is used to rule in myelogenous leukemia. Okay, so si MPO and SBB, ito yung mga cytochemical stain used to rule in myelogenous leukemia. Ito din yan, just the same with dito. Using MPO and SBB kapag positive, ibig sabihin myelogenous in origin. Kapag negative, lymphocytic in origin. So from here, another is we have the esterase stain. Sa esterase stain, meron tayong tinatawag na A, B, and C. We have acetate esterase, butyrate esterase, and chloroacetate esterase. Butyrate and chloroacetate. Si acetate and butyrate, these are non-specific esterase. So, ibig sabihin ng non-specific, positive siya to all WBC. Mapa-lymphocyte, mapa-granulocyte, mapa-monocyte. Ang acetate and butyrate esterase stain is a non-specific esterase, so ang expected result, positive siya for all WBCs. Pero, it will be strongly positive for monocyte. So, strongly positive siya for monocyte only. Si chloroacetate, this is a specific esterase stain found only in granulocytic series. So, ibig sabihin, kapag si chloroacetate yung ginagamit, we are trying to determine if granulocytic ba yung mga cells. Okay? Granulocytic in origin. So, mga neutrophils, eosinophils, basophils. Kasi siya lang yung magpa-positive sa chloroacetate esterase stain. So, for monocytes, so meron tayong ginagamit for granulocytic series, si chloroacetate. For monocytes, monocytes contain lysosomes or yung muramides. Actually, pati si si neutrophils. Meron din siyang lysosomes. So this is ID'd or identified. Pag sinabing ID, identified or identification, di ba? This is ID'd histochemically or identified histochemically by strong staining reaction in non-specific esterase. Ulit. So ang cytochemical stain for leukemia, ang ginagamit natin is CMPO, SBB, and naphthol ASD chloroacetate. So itong tatlong to ginagamit to rule in myelogenous leukemia. Ang myelogenous leukemia, dalawa, granulocytic or monocytic. So gagamit tayo ng esterase stain. Ang acetate and butyrate are non-specific esterases, positive for all WBCs, pero kapag monocyte ang cell, strongly positive si acetate and butyrate. So in order for us to differentiate monocytic from granulocytic, gagamit tayo ng chloroacetate specific esterase stain. Kasi si chloroacetate, positive lang siya kay granulocytic series. Again, sa monocytes, to differentiate from granulocytes, kay monocytes non-specific esterase reaction. Next. Wait lang, meron pa ako isa idadagdag dito. Okay, so yan na yung leukemia. Yan na yung buong leukemia. So catch up na lang kayo sa notes. May dadagdag ako kasi wala dito sa notes. So merong leukemia, iba pa tong lymphoproliferative disorders. So we have lympho, okay, we have lymphoproliferative disorders. Iba to sa leukemia. Sa lymphoproliferative disorders, from the prefix lympho, merong, and proliferative, ibig sabihin pagdami, merong proliferation of cells derived from lymphoid origin. Okay, it may be T or B cell. Ang number one dyan, iba to sa leukemia kasi we have lymphoma. Lymphoma is an example of lymphoproliferative disorder. Merong abnormal proliferation of cells derived from lymphoid origin. Ang pinagkaiba nito sa leukemia, ang leukemia, bone marrow. Sa bone marrow pa lang may problem na. Dito, sa lymphoproliferative disorders, nagkakaroon ng problem sa primary lymphoid organs or secondary lymphoid organs. One example of secondary lymphoid organ is lymph nodes. So ang lymphoma, ang affected na organ dito is sa lymph nodes. So we have lymphoma. Sa lymphoma, merong malignant cells in secondary lymphoid organ. So ano yung mga secondary lymphoid organs? Spleen, liver, lymph nodes. So we have non-Hodgkin's. Actually affected pa rin yung bone marrow dito eh. So malignant cells in lymphoid organs na lang. Pero ang pinaka-affected kasi yung secondary. So lymphoid organs such as spleen, liver, lymph nodes, bone marrow. So we have non-Hodgkin's lymphoma. And we have Hodgkin's lymphoma. Si non-Hodgkin's, proliferation of malignant lymphocytes. Sa Hodgkin's lymphoma, merong proliferation of cells reacting to neoplasms. Dito, nakakakita tayo ng tinatawag na Reed-Sternberg cells na merong Au's eye appearance. So sa Hodgkin's lymphoma, tandaan nyo na lang yung keyword, merong Reed-Sternberg cells. So ano yung itsura ng Reed-Sternberg cells? Aus eye appearance. So ang diagnosis dito, sa dalawang to, is lymph node biopsy. Lymph node biopsy. Next. Next, we have, after ng lymphoma, we have hairy cell leukemia. Sa hairy cell leukemia, hindi ko na isusulat, total na-discuss na kanina. So, ang tandaan nyo lang sa hairy cell leukemia, merong mga lymphocytes na may mga hair-like projections, and it is TRAP positive or tartrate-resistant acid phosphatase positive. Next, we have mycosis fungoides, and Sézary syndrome. Ito ay T cells in origin, nagkakaroon ng Sézary cells. Anong meron sa Sézary cells? Cerebriform nucleus. Yun lang sa lymphoproliferative disorders. Kasi ang next natin is myeloproliferative disorders. So ito lymphocytes. Ang next, so screenshot nyo na lang, ever mabilis. Ang next is myeloproliferative disorders. So just like myelogenous, so myeloproliferative disorders. Kung babalik tayo sa hematopoiesis, di ba we have CLP and CMP. Itong myeloproliferative disorders are proliferation of cells derived from myeloid stem cell. So going back sa hematopoiesis, ang hematopoietic stem cell will divide into two, CLP and CMP, common myeloid progenitor. Sa myeloproliferative disorders, affected ang granulocytes, affected ang monocytes, affected ang RBC, affected ang platelets. Kaya nga, myeloproliferative disorders. So number one example is we have CML, chronic myelogenous leukemia. Ito, though wala naman masyado dito aside sa translocation of chromosome 9 and 22. So sa CML, yun na nga, merong translocation between chromosome 9 and 22. Ang tatandaan nyo lang dito sa translocation na to, ang involved na gene is si BCR-ABL1. Ang platelet count can be greater than 600 times 10 to the 9 per liter. Ang normal is 150 to 450,000. So it's either ang platelet count is sobrang taas or sobrang baba, less than 50 times 10 to the 9 per liter. Ito yung tinatawag na merong Philadelphia chromosome, or yung tinatawag na chromosome 22. Ito yun. So si CML, madalas siyang nako-confuse with leukemioid reaction. So ang ginagamit for leukemioid reaction is LAP score or leukocyte alkaline phosphatase. So ang LAP score ng CML is decreased. Ang leukemioid reaction increased. Next we have, ililista ko na lang pero wag na natin i-complicate. We have MMM or myelofibrosis with myeloid metaplasia. Dito sa myelofibrosis with myeloid metaplasia, ito yung mga myelodysplastic disorders, in a sense na yung bone marrow napapalitan ng fibrotic tissue. And then merong metaplasia kasi metaplasia, metastasize, kumalat na. Merong proliferation of cells in spleen and liver, aside sa bone marrow. Next, we have, sa RBC to, PV or polycythemia vera. Okay? This is an example of panmyelosis. Ibig sabihin ng panmyelosis, mataas ang WBC, RBC, platelets. Then we have essential thrombocythemia. Ang platelet count is greater than 1,000. Yun lang. Yan yung mga examples of myeloproliferative disorders. So tatandaan lang dyan, since myelogenous or myeloid stem cell ang na ang defect ay nasa myeloid stem cell, ang granulocyte, monocytes, and RBC, and platelet count. Lahat sila affected. So examples of myeloproliferative disorders, we have CML, MMM, polycythemia vera, and essential thrombocythemia. Okay, so screenshot. Okay, next lab, proceed na tayo sa lab. Next, we have, ito na yung mga sunod-sunod na laboratory test. Let's begin with blood smears. So sa blood smear, gumagamit tayo ng Romanowski type of stain and supravital stain. Yung Romanowski type of stain, it is pH dependent. Tatandaan tong pH na 6.4 to 6.8 kasi dapat ang pH ganyan. Otherwise, if acidic or alkaline ang stain, magkakaroon ng effect. So it is pH, it is heavily dependent sa pH na 6.4 to 6.8. So it is a polychrome stain consisting of two types of dye. Walang primary stain dito, walang secondary stain dito. Applicable lang yan sa gram stain, sa bakte. Ang Romanowski type of stain, meron siyang two types of dye. So ito yung ginagamit natin routine. We have the methylene blue and eosin. Si methylene blue or the azure stain, it stains the acidic components of cell. Ang color ng mga acidic components of cell is blue or purple. We have the eosin, it stains the basic cellular components, orange to red. Si Romanowski type of stain contains methanol as a fixative to fix the smear. So ayan, acidic components are basophilic, so ang color is blue or purple. What are examples of acidic components? We have WBC nuclei, RNA remnants, and platelets. Then we have the basic components which are acidophilic or eosinophilic. Ang example ng acidophilic, example ng mga basic components na acidophilic is ewan ko kung may kita. Oo, yung cytoplasm. Acidic. These are the proteins and amino acids. Ulit, mas gusto ko siyang isulat. Si Romanowski stain, meron siyang methylene blue and eosin stain. Eosin stain or otherwise known as eosin B or eosin Y. Si methylene blue, this is a basic stain. Basic stain for acidic components such as DNA and RNA. Ang color is blue and purple. Si eosin B or eosin Y is an acidic stain. Ini-stain niya yung mga basic components such as proteins and amino acids. So ang color is orange or red. So examples of Romanowski type of stain is Wright stain and Giemsa stain. Another example is May Grunwald stain. So si Wright, Giemsa, example sila ng Romanowski stain. Bakit sila Romanowski stain? Kasi meron silang two components, methylene blue and eosin. So this methylene blue and eosin, we will be able to stain the different components na meron ng isang WBC. Next, ito naalala ko na. So si eosin, acidic stain siya. It stains the basic components of cell, orange or red. Ang primary example natin dito are the red blood cells. Example of proteins or amino acid is hemoglobin. Kaya ang nag-i-stain sa red blood cells, kaya siya salmon pink cytoplasm, that is due to the eosin. Next, we have supravital stain. So supravital stain, it stains the cell at living state and meant to demonstrate cytoplasmic structures only like reticulocyte. Examples of supravital stain, we have NMB, Janus green, neutral red, and brilliant Crescent blue. So si supravital stain, ginagamit to mostly for reticulocyte. Sabi natin, there are reticulocytes na nakikita sa peripheral blood, pero small percentage. That is true. Pero if using Wrights or Giemsa, hindi natin makikita yung reticulocyte. We will not be able to see the presence of reticulocytes in blood smear if ang gamit natin ay Wrights and Giemsa. For us to see yung reticulum, gagamit tayo ng supravital stain. Next, we have criteria of a good stain. Macroscopic, it should be reddish, brown, or pinkish. Pag microscopic, the red blood cells should be pink to salmon. Nuclei are dark blue to purple. Granules of neutrophils should be lavender to lilac. Basophils, dark blue to black. Eosinophils are red to orange. Ito alam niyo lumalabas to, lagi. So aaralin tong staining problems and yung troubleshoot na gagawin. Okay, so ang routine na ginagamit natin is yung Romanowski scale na Wrights or GIMSA. Kapag hindi na-maintain yung pH, naging extremely red or acidic yung smear, RBCs would appear bright red or orange. Nuclear chromatin of WBCs would appear pale blue. Eosinophilic granules would appear sparkling brilliant red. Ano yung mga causes of extremely red or acidic smears? Hindi na-maintain yung buffer, hindi na-maintain yung pH, merong excess buffer, excessive washing, sobrang nipis ng smear, exposure of the buffer stain to acid fumes, cold stain where methanol has oxidized to formic acid. Next, extremely blue or alkaline smears. Ganun ulit, hindi na-maintain yung pH. The pH is greater than 6.4. Makapalang smear, inadequate washing, excessive washing time, short drying period. Ang ginamit is heparinized blood instead of using EDTA. RBCs would appear blue or green. Eosinophil granules would appear blue to gray. Heparinized samples are not acceptable for WBC count because it imparts blue to green background. Then magkakaroon ng presence of precipitation. Kailan nagkakaroon ng presence of precipitation? Inadequate washing, inadequate filtration of stain. So ano yung color ng precipitate? Purple to blue and can be mistakenly recognized as lymphocytes or leukocytes. Next, peripheral smear, examination. Lagi tayong nag-start sa 10. So this is necessary to assess the overall quality of smear. Itong 40 and 50 objectives, hahanapin natin yung field wherein cells do not overlap. And ginagamit din to determine the average number of WBC per field. Then we have the WBC estimate. If 40 ang objective na ginamit, ito yung formula. And ito yung WBC estimate. If 50 ang objective na ginamit, ito yung formula. Yan, kaya na yan. If 100, yun yung ginagamit for differential. If estimate lang kasi, binibilang natin yung WBC. Pag sinabi ng differential, ito na yung kinakategorize natin if neutrophil A o basal monocyte lympho. Tinitignan din natin under 100 times objective, yung abnormalities sa WBC and presence of NRBCs. Next. So ito yung differential count and their relative percentage. Next, let's proceed sa evaluation of erythropoiesis. Ito pasapasada lang to. For evaluation of erythropoiesis, it is categorized under total, effective, or ineffective. Si total, effective, and ineffective, pag sinabing total, yung total blood cells, total RBC. Kapag sinabing effective, these are the quantification of RBCs that reach the circulation. Then we have ineffective erythropoiesis. These are the RBCs that never reach the circulation. So for the measurement of total erythropoiesis, we have bone marrow examination or aspiration. So ginagawa to sa posterior iliac crest and sternum. We have the iron 59 or plasma iron turnover. So keywords na lang ang mga tandaan nyo dito. Ito kasing sa plasma iron turnover, parang paiinumin si patient ng yung tinatawag na i-inject pala, kala ko iinumin. I-inject kay patient yung radioactive iron or iron 59. If normal, ang total erythropoiesis, 70 to 75% of plasma iron is used up by RBC. Then we have the erythropoietin assay to differentiate primary polycythemia from secondary erythropoiesis. Then we have the measurement of effective erythropoiesis. So number 1 dyan, ang reticulocyte count. So paulit-ulit na ako before, ang reticulocyte count is ginagamit to assess the status of bone marrow pertaining to erythrocyte production. Or in other terms, to assess the bone marrow's ability to increase red blood cell in response to anemia. Ang normal value ng reticulocyte count is 0.5 to 2.5%. So ang anemia, it is classified depende sa reticulocyte count. So yan yung classification niya. Next, we have measurement of effective survival of erythrocytes in blood. So we have radioactive chromium. So chromated red cells are injected. Basta tatandaan nyo lang tong radioactive chromium. So ginagamit siya for effective survival of erythrocytes. Next Next, measurement of total destruction of red cells. So if we are talking about total destruction of red cells, babalik ulit tayo sa extravascular or intravascular hemolysis. So it involves hemoglobin breakdown. So gumagamit tayo ng free hemoglobin, haptoglobin, and determination of fecal urobilinogen. See, determination of fecal urobilinogen, it estimates the total excretion of bile pigments or breakdown products of heme. Ayan. Reduced in aplastic anemia, blah, blah, blah. Ano ba? Bakit ito may blank? Hindi ko alam bakit ko nilagyan siya ng blank. Anyway, next, evaluation of erythrocyte structure and function. So we have measurement of the oxygen carrying capacity of the blood for the diagnosis of anemia or decreased oxygen carrying capacity. So we have ang RBC count and hemoglobin determination. So for RBC count, this is obtained using automated method. Ang principle is resistance pulse counting or electric impedance. So later, i-discuss natin yon. Next, we have hemoglobin determination. Ang reference method is the methemoglobin method or hemoglobin cyanide method, high na high. Kasi dating term for methemoglobin is hemoglobin. Hemoglobin cyanide method. So that is the reference method for hemoglobin determination. Quantitative procedure, ang UV visible spectrophotometer. Dito sa hemoglobin determination, we have cyan, met, hemoglobin method. So ang principle nito, ang hemoglobin na merong ferrous ion plus hemoglobin na merong ferrous ion plus potassium ferricyanide, potassium ferricyanide, potassium ferricyanide. So si hemoglobin plus potassium ferricyanide magiging methemoglobin. Dadagdagan natin ng potassium cyanide. So magiging cyan methemoglobin. Dito sa hemoglobin method, hindi kasi quantifiable ang hemoglobin. Para ma-quantify ang hemoglobin, kailangan siyang i-convert sa cyan methemoglobin. Ang cyan methemoglobin is measurable or quantifiable. So if we want to determine the hemoglobin content of the RBC, kailangan natin i-convert si hemoglobin to cyan methemoglobin. Two-step method to. Kasi si hemoglobin, kailangan mo na siya i-convert sa methemoglobin. Si methemoglobin, i-convert sa cyan methemoglobin. Si potassium ferricyanide, so sulat nyo na lang, potassium ferricyanide converts methemoglobin to cyan methemoglobin. Si potassium cyanide reagent provides the cyanide ion. Okay, interferences. Okay, so alam ko medyo pagod na kayo, pero wag ine-neglect ang laboratory evaluation ha. Remember, sa board exam, malaki ang percent nito. Interferences, nagkakaroon ng falsely increase kapag mataas ang WBC count, mataas ang platelet count, merong lipemia, merong HBS, and HBC. So nagkakaroon ng false increase in hemoglobin determination in cases of leukocytosis, thrombocytosis, lipemia, hemoglobin S, and hemoglobin C. Okay, next. Next, we have the indices. So sa indices, we have 3, MCV, MCH, and MCHC. Si MCV, average volume of red blood cell, expressed in femtoliters. So ito yung formula ng MCV. Hematocrit times 10 divided by RBC per liter. Or, ang other formula niya is hematocrit times 1,000 divided by RBC per microliter. So, example, ang patient natin, ang hematocrit niya is 35%. 35% or 0.35. Yan, SI or conventional. Ang RBC count is 4.0. So, either times 10 raised to 12 per liter or microliters yung isa pa. So, i-apply natin. 35% times 10 divided by 4.0. Wait lang, kakalculator ko. 35% times 10 divided by 4.0. 35, 0.35 times 10. 3.5 divided by 4.0. So, 87.5. Or, yung isang formula, 0.35 times 1,000 divided by 4.0. Or 0.35 times 1,000 divided by 4.0. So 87.5. Ito yung MCV, femtoliters. Para hindi kayo malito, dito sa 35%, huwag niyong ilagay yung percentage. Kasi pag nilagay niyo yung percentage, magiging 0.35 siya. So 35 lang. 35 times 10 divided by 4. Pero kapag 0.35, i-multiply niyo sa 1,000. So ang MCV, ang reference range niya is 80 to 100 femtoliters. If less than 80 ang MCV, cells are considered microcytic, as seen in iron deficiency anemia and parasitism. If greater than 100, the cells are macrocytic, seen in pernicious anemia and megaloblastic anemia. So MCV is the ratio of average concentration. Wala. Okay na yan, as is, MCV. Kasi average concentration sa MCH yun. Okay, next, for MCH, it indicates the average weight of hemoglobin in blood cell expressed in picograms. So actually, si MCH, hindi siya ginagamit. This is not used to classify anemia. Classify anemia according to, basta sa tatlong indices, hindi masyadong ginagamit si MCH to classify anemia. So si MCH, ang formula niya is hemoglobin grams per DL times 10 divided by RBC, or hemoglobin in grams per DL divided by RBC. So i-apply natin, same patient. Si patient, ang hemoglobin niya is 14 grams per deciliter. Ang RBC niya is 4.0 times 10 raised to 12 per liter. So i-apply natin yung formula. Hemoglobin in deciliter, 14 times 10 divided by 4.0. 14 times 10 divided by 4.0. This is equals to 35. 35 picogram. So ang reference range is 27 to 33 picogram. If less than 27, microcytic, hypochromic. If less than 33, spherocytosis or hyperchromic. Si MCH, this is directly proportional to the amount of hemoglobin and size of red blood cell. Okay, next we have MCHC. Naputol, MCHC. Si MCHC, it indicates the average content of hemoglobin in the RBC. Or ito yung average concentration. Average concentration of hemoglobin in red blood cell. So ang formula ng MCHC is hemoglobin times 100 divided by hematocrit. Specifically, hemoglobin in grams per deciliter divided by hematocrit. So, calcu. Kasi ito hematocrit in percent. So, i-apply natin yung previous example. Ang hemoglobin ni patient ay 14. Ang hematocrit, 0.35. 14 divided by 0.35 is equals to 40. Gamitin natin yung isang formula. Hemoglobin, 14 times 100 divided by hematocrit in percent, 0.35. Bakit ang laki? 14, 100. 14 times 100 hematocrit. Hindi natin ipa-percentage. Percent lang yung unit. Hemoglobin times 14 times 100, 14 times 100 divided by, ano yung hematocrit natin, 35. Okay, so 14 times 100 divided by hematocrit in percent, which is 35. So same answer, 40. Ang unit is gram per deciliter. So si MCHC, ang reference range niya is 33 to 36 gram per deciliter. So if less than 33, it indicates hypochromia. If greater than 36, it indicates hyperchromia. So these are the interferences that can affect MCHC. According to Rodax, it is impossible na ang MCHC can be greater than 37. So kung tutuusin daw, walang MCHC na greater than 37. Kasi pag merong greater than 37 na result, it is a sign of machine error. Kasi the RBC cannot hold more than 37 of hemoglobin. So it is impossible daw na magkakaroon ng MCHC na 37 and above. If meron daw nun, i-check yung machine kasi sign of machine error siya because theoretically ang RBC hindi niya kayang maghawak ng hemoglobin with a concentration of greater than 37 grams per DL. Next, we have red cell distribution width. So si RDW, ang tatandaan lang dyan, anisocytosis. So si RDW, it estimates erythrocyte anisocytosis. Kapag mataas ang RDW, ibig sabihin, merong appearance of different sizes of cell. Microcytic, normocytic, macrocytic. So itong table na to, ayan. Kailan nagkakaroon ng increased RDW and then ang MCV is decreased, ito yung mga condition. If ang RDW increased pero ang MCV normal, ito yung mga condition. If ang RDW increased, ang MCV is increased, ito yung mga condition. Dissect natin ng konti lang. RDW increased, pero ang MCV decreased. So microcytic. Ano yung mga microcytic cells? Iron deficiency anemia, sickle cells. Next, RDW increased, MCV increased din. So ano yung mga conditions? Megaloblastic pernicious folate, chronic liver disease, chemotherapy, cold agglutinin disease. Next, test for abnormal hemoglobins and derivatives. Ayoko na sanang tinuturo to kasi obsolete na to, pero you never know. So kapag bright red ang hemoglobin, we have shaking. So dati pa ito ginagawa. Whole blood is shaken for 15 minutes. The expected colors formed are as follows. Bright red kapag oxygenated hemoglobin, cherry red kapag carboxy hemoglobin, chocolate brown kapag hemoglobin, ang high I met hemoglobin ha, mauve lavender kapag sulf hemoglobin. Next, spectrophotometry. So ang carboxy hemoglobin, ang wavelength used to detect carboxy hemoglobin is 555. For met hemoglobin, 630. For sulf hemoglobin, 620. Next, determination of fetal hemoglobin. In cases of HPFH or hereditary persistence of fetal hemoglobin, ibig sabihin, sobrang taas pa rin ang percentage ng fetal hemoglobin sa adult. Dapat normally less than 2%. So for the determination of fetal hemoglobin, we have alkali denaturation test and acid elution test. Sa alkali denaturation test, this is a colorimetric. So principle, hemoglobin fetal resists alkali denaturation while HbA does not, or adult hemoglobin does not. Okay, yun lang. Next, acid elution test or Clay-Hauer-Betke or Braun. So cytochemical method for hemoglobin determination, gumagamit ng citric acid phosphate buffer. So ganun ulit, cells containing fetal hemoglobin would resist acid elution. Next, electrophoresis. Hemoglobin molecules in an alkaline solution have a net negative charge and will move towards the anode. So sa electrophoresis, from the negative charge, magkakaroon ng movement papunta sa anode or positive charge. So first, we have the cellulose acetate agar at an alkaline pH. So ito yung ginagamit muna primarily. Kaya nga ang tawag dito, screening method. So primary screening method is the cellulose acetate agar. Alkaline, pH 8.4 to 8.6. Tandaan yung mga pH ha. So meron tayong fast hemoglobins. Fast hemoglobins include, in order of increasing mobility, we have HBS, KJ, BARTS, and IH. Yung mga fast hemoglobin, so dito ang origin, cathode, papunta sa anode. Yung mga tinatawag na fast hemoglobin, so ito agad yon. Ano yung mga abnormal hemoglobin? Yung ibang color. Yung SDGL, yan yung mga abnormal hemoglobin. Kasama yung CEO, abnormal hemoglobin yan. Pero another. So iniba ko yung kulay niyan kasi abnormal hemoglobin sila. Plus, sila yung magkakasama. Sa cellulose acetate agar, ang magkakadikit sa electrophoresis is si SDGL. Ang palatandaan ko nga dyan is Sara D. Geronimo. Hindi ko na tinatandaan tong L. Ang next na magkakasama sa electrophoretic mobility is yung CEO. So how can we differentiate SDG and CEO? Gagamit tayo ng citrate, agar, at an acid pH of 6.2. Ulit ha, ang abnormal hemoglobins na nakikita sa cellulose acetate agar na magkakatabi or same mobility is SDG, tsaka CEO. To differentiate S from D and G and to differentiate C from E and O, gagamit tayo ng citrate agar at an acid pH of 6.2. Before we proceed sa citrate agar, when it comes to normal hemoglobin, kapag normal hemoglobin, ang fastest is si A1 or A. Ang slowest is si A2. Fastest A or tinatawag na A1, ang slowest is si A2. Next citrate agar. So si citrate agar, this is used to separate hemoglobins that migrate together. Sino nagmamigrate together? Sara D. Geronimo. Tsaka si CEO. So to determine kung S ba siya or C ba siya, gagamit tayo ng citrate agar. So yun lang. Through citrate agar, we can differentiate S from D and G, C from E and O. Next, polyacrylamide gel, sharp separation of hemoglobin variants. Next, test to detect the presence of HBS. We have cycling test or metabisulfite, slide test, or so principal addition of sodium metabisulfite to blood to enhance the oxygenation of hemoglobin and cycling of hemoglobin S. Method of determination, microscopic, because you determine the extent of citric number of sickled cells after treatment with sodium metabisulfite, which deoxygenates and produces HBS, causing the HBS-containing cells to sickle. Basta ang nangyayari dito sa sickling test, nag-a-add tayo ng sodium metabisulfite. If the RBC contains the abnormal variant of hemoglobin, which is HBS, magkakaroon ng sickling. Ngayon, kung wala namang sickling, ibig sabihin walang HBS yung RBC. Next, we have sickle solubility test. Red cells are lysed with saponin. Hemoglobin is reduced by dithionite. Reduced hemoglobin S is insoluble in concentrated inorganic buffer, 2.3 m phosphate buffer, and the polymers. So ito, sa sickle solubility test, turbidimetric. Si sickling test, microscopic. Si sickle solubility test, turbidimetric. So if merong HBS, magkakaroon ng positive results sa turbidity. So tatandaan lang dito si dithionite. Ano yung function ni dithionite? Yung pag-reduce sa hemoglobin S. Si 2.3 m phosphate buffer, siya yung nagpe-precipitate ng oxygenated hemoglobin. Ano yung naglalyse ng RBC? Saponin. Next we have hematocrit. Expound natin. Lumalabas kasi ito madalas eh. So sodium dithionite. Ito yung reducing agent. Si sodium saponin, hemolytic agent. So if positive sa HBS, magkakaroon ng turbid appearance. Turbid appearance kasi yung HBS nagpo-form siya ng liquid crystals. Yun lang for sodium sickle solubility test. Next, hematocrit. So hematocrit represents the proportion of RBC to plasma in peripheral blood. Ang other term for hematocrit is packed cell volume. Procedure, EDTA blood or capillary blood in heparinized tube. Ang capillary tubes, ang length 75 mm long with ID internal diameter of 1.155 mm. Ang blue band capillary tube is used with EDTA. Ang blue band kasi no anticoagulant. Si red band meron siyang anticoagulant na heparin or heparinized. Kaya si red band ginagamit to for capillary blood. Pero if EDTA ang gagamitin, blue band capillary tube. So fill tube to about 3/4, no bubbles or spaces in between. Centrifuge for 5 minutes at 10 to 15,000 RPM. Ang hematocrit, eto na nga, babalik tayo sa recall question. Ang hematocrit is MCV times RBC count. So sa automated procedures, MCV times RBC count. Reference range for male, 40 to 54. For female, 37 to 47, newborn, 44 to 64. Okay, mataas ang hematocrit ng newborn, kaya sa internship ninyo, if nag-manual method kayo, manual method yung sa Capilet method, tapos nabasa ninyo mataas, it is normal for newborn. Okay, clinical significance, if mataas ang hematocrit, polycythemia, ang daming red blood cells. If mababa ang hematocrit, anemia or blood loss. Ibig sabihin, yung ratio ng RBC against plasma is mababa. So there are sources of error. Wala naman akong masyadong i-add dyan, so that would be as is. Iiwanan ko na sa inyo para basahin. Next, we have erythrocyte sedimentation rate. So si ESR, ginagamit to mostly for inflammatory conditions, pero non-specific. This is used as a non-specific test for inflammation. Kasi hindi ibig sabihin na mataas ang ESR, automatic may inflammation. There are a lot of factors which could affect the result of ESR. Si ESR, it measures the rate of settling of erythrocytes from diluted plasma. So we have two methods, Winthrop and Westergren. Ang magkaiba, yung anticoagulant na meron sila, and yung tube in terms of graduation and bore. So tignan nyo na lang din, basahin nyo na lang din, lumalabas po sila kasi ito po yung mga lumang methods na up until now is ginagamit pa din. In ESR, there are 3 phases. Agglomeration phase, that is the first 10 minutes. Phase of fast settling, which is the next 40 minutes. And yung final phase of packing, or the last 10 minutes. Procedural considerations. Heparin is not an acceptable anticoagulant. Rate of settling depends on an interrelationship of variables. So sabi ko kanina, si ESR, non-specific test, or ginagamit siya for screening. Ang RBCs, babalik tayo. Ang RBCs, meron silang net negative charge. So normally, RBCs would repel each other. Kaya ipapasok natin yung blood bank, ang RBCs, ito yung RBCs, meron silang negative charge. Since meron silang negative charge, they would repel each other. Hindi sila magdidikit-dikit. Unlike kay platelet, si platelet, it is their nature to aggregate with each other. Ang RBCs, it is their nature to repel each other, ang maglayo-layo. Kaya during cross-matching, gumagamit tayo ng enhancers such as LISS and albumin to reduce the zeta potential or to reduce the negative charge. Para if merong antibody, antigen complex, magkakaroon ng agglutination. Ano ang kinalaman ng ESR doon? So ang RBCs, negative charge. So since merong negative charge, magkakaroon ng slow settling of RBCs. So ang ESR, di ba 1 hour yan? In inflammatory conditions, nagkakaroon ng decrease in negative charge. Therefore, nagkakaroon ng increased RBC settling. So if mataas ang ESR, if nagkaroon ng increased RBC settling, it means na merong inflammatory conditions. These inflammatory conditions could decrease the net negative charge, thereby increasing the RBC settling. Next. Last na. Malapit na tayo. Malapit na to. So ito po ha, lumalabas po to lagi. So aaralin itong table na to. Hematocrit and ESR. Sulat ko na lang ha, HCT and ESR. If using yung Winthrop tube, nakakita na ba kayo ng Winthrop tube? I don't know if nagawa niyo to sa laboratory. So meron kasi tayong Winthrop tube. Double graduated kasi to. Ibig sabihin, dalawa yung graduation niya. Dalawa kasi ang purpose niya. Pwedeng gamitin yung Winthrop tube sa hematocrit, pwedeng gamitin yung Winthrop tube sa ESR. I hope nagawa niyo to during your 3rd year. So yung hematocrit, ang graduation niya is nakikita sa right side. Ang color nito is white. Yung ESR, nakikita yung graduation nito sa left side. Ang graduation nito, ang marks ay color red. From the top, mag-i-start to sa 10 cm, papunta sa bottom na 0. Baliktad sa ESR. Ang top ng ESR is 0, papunta sa 10 which is yung bottom. Reference range for ESR, na ba nakalagay dito? For ESR, adult males, 0 to 10 millimeter per hour. For females, 0 to 15 millimeter per hour. Itong 0 to 10, if ang ginamit na method is modified Westergren. Kapag ang ginamit na method is Winthrop tube, ang normal value is 0 to 9 millimeter per hour. For females, 0 to 20 millimeter per hour. And additionally, iba-ibahin natin yung methods. Kapag Westergren, dito na lang. So kapag Westergren, pag Winthrop, double oxalate. Pag Westergren, 3.8% sodium citrate, black top. Kapag modified Westergren, ito na yung ginagamit natin, EDTA. Ito na yung ginagamit mostly sa laboratory. Next, we have reticulocyte count. So for reticulocyte count, ang stain na ginagamit is NNB. Pwede rin ang BCB, pero much preferred ang NNB. Okay, i-dissect natin si NNB. Meron siyang sodium oxalate and sodium citrate. Si sodium oxalate, it prevents coagulation, while si sodium citrate provides isotonicity. Next, ano yung isang stain na ginagamit? We have BCB, Brilliant Crescil Blue. Si Brilliant Crescil Blue, hindi na siya masyadong ginagamit kasi inconsistent ang staining result. Si BCB, meron din siyang sodium citrate and sodium chloride. Si sodium citrate, it prevents coagulation. Si sodium chloride provides isotonicity. So supravital stain would bind and neutralize cross-link RNA. So in other words, si NMB kaya niyang ipakita yung reticulum. Reticulum is composed of RNA and ribosomes. Specimen, EDTA or heparinized blood. So 1:1 ang ratio. 2 drops of blood and 2 drops of NMB. Stand for 10 to 15 minutes, and then magi-smear and then i-examine under OIO. Next, clinical significance. Increased retics is an indication of a bone marrow compensatory mechanism. So, increased retics, it is the first sign of accelerated erythropoiesis. Accelerated erythropoiesis or bone marrow compensatory mechanism. Ano yung mga increased retics? Blood loss, hemolytic anemia, malaria, blood intoxication, lead poisoning. Decreased retics, aplastic anemia. So aplastic anemia, bone marrow is not producing cells. Chemotherapeutic or radiation-induced hypoproliferation, pernicious anemia or megaloblastic anemia due to ineffective erythropoiesis. So ito yung mga other formula. So again, lumabas ang formula ng CRC sa recently concluded board exam. Next. Okay, methods of counting. Huwag natin skip to kasi importante to. So sa reticulocyte count, ang retics count is number of retics divided by 1,000 RBCs times 1,000. Pag absolute reticulocyte count, ito, absolute reticulocyte count, so times 10 to the 9 per liters ang unit nito, number of retics times RBC count times number of retics times RBC count divided by 1,000. Magkaiba kami nito ni Book. Retics is, wait lang ha, gagawa ako ng sample. Ang na-count na retics ay 24. Ang na-count na retics sa smear ay 24. Ang RBC count is 4.0 times 1,000 divided by 1,000. So 24 times 4.0 times 1,000 divided by 1,000. 24 times 4.0 times 1,000 divided by 1,000. 96. I-apply natin yung isang formula. Yung isang formula is reticulocytes 24 times 4.0 divided by 100. 24 times, or 24 divided by 100 times 4.0. 0.96. Kasi kung ito yung susundin, reticulocytes in percent. So, kunyari, ang reticulocytes ay 24 divided by 100. So, 0.24 times RBC count, 4.0. So, ang lumalabas kasi dito, 0.96. Mas gusto ko yung sa akin. Ito kasi saktong 96 na yung i-release niya. So, ang reference range for ARC is 20 to 115. Next, we have OFT, or osmotic fragility test. Whole blood is added to a varying concentration of NSS. Ito yung serial dilution. Tapos ine-expose yung cell sa different isotonicity. Pag isotonic ang solution, molecules will pass in and out of the cell. Pag hypotonic ang solution, water molecules will accumulate inside the cell. So magkakaroon ng hemolysis kasi sa hypotonic solution, kung nasa ng tubig, nandun din ang sodium. So nagkakaroon ng imbalance between sodium and potassium. So nangyayari, nagkakaroon ng cell burst. Kasi punong-puno yung RBC ng tubig. So, nangyayari yun kapag hypotonic ang solution. Next, we have hemocytometry. Nahiwalay. So, ito po yung grading ha, RBC, morphology grading. We have the laboratory features of myeloproliferative neoplasms. Polychromasia grading. And reference values ng lahat. So next is RBC automation. So mag-break muna kayo ng 5 minutes kasi mahaba yung isusulat ko dito. Pero puro keywords na lang. Sa RBC automation, we have the Coulter principle or electric impedance. Ito yung most common na ginagamit. So ito yung principle ng machine na ginagamit natin sa mga hospitals. So, di ba, sa CBC, we have RBC count, WBC count, platelet count, and then WBC differential count. Paano binibilang yung cell? So, through electrical impedance. Cells are sized and counted. So, inuuna, dinadetermine kung ano yung size ng cell, saka siya bibilangin. Depende sa sizes ng cell. So, blood, so dadaan sila sa mga tinatawag na aperture. Blood is diluted in saline. So, saline is a good conductor of electricity. So, merong two electrodes ginagamit natin, external and internal. Ito lahat ay i-memorize nyo lang. So, si external and internal electrode. So, electrical impedance occurs as the cell pass through the aperture, causing a change in voltage. So, just a quick, so sa picture na to, yung mga cells, ito yung mga RBCs, Ayan, dadaan sila sa tinatawag na aperture. Ito yung aperture. Depende sa size nila, ika-categorize mo na yung size nila. Sa bawat size, parang pulso, kaya nga electrical impedance or pulse generated counting, sa kada daan ng cell, parang may tumitibok. So, nagpapulsate. Okay? So, nagde-develop ng pulse. So, it is generated during a change in voltage. Yung number of pulses is equals to the number of cells. The size of voltage pulse is equivalent to the size of the cell. So, bibilangin niya RBC, WBC, platelets. For RBC chamber, kapag 2 to 20 yung size, yung femtoliters, ika-count niya yon as platelet. If ang na-detect niyang size ng cell na dumaan sa aperture is 36 to 360 femtoliters, ika-count niya yon as RBC. Okay? So, dito na-determine yung count. Depende sa size. Yung count depende sa pulse. Yung pag-identify is depende sa size. Ano yung size? Yung femtoliters. Kapag 36 to 360, RBC. Kapag 2 to 20, platelet. Question, nasaan dyan ang WBC? So, uunahin mo ng bilangin ng RBC and platelet. Next na bibilangin is WBC. Okay? Since medyo magkatulad ang size ng WBC and platelets, kasi di ba may lymphocytes, almost the same size ng RBC. Okay? So, sa WBC count, kailangan mo na gumamit ng pang-lyse. Lyse reagent to lyse RBC. And then, so pag na-lyse na yung RBC, ika-count na niya yung WBC. Pag ang machine tinawag na 3-part differential, kaya lang niyang i-categorize ang WBC according to granulocytes, lymphocytes. I forgot kung ano tong MID. Monocyte. Monocyte ID. Monocyte identification. So pag 3-part differential ang machine, kaya lang niyang i-categorize kung granulocyte, lymphocyte, and monocyte. Kaya kapag ang machine ay 3-part differential, kailangan gumawa ng smear at saka doon magko-conduct ng WBC differential counting. Kasi si 3-part differential, hindi niya kayang i-differentiate kung neutrophil, eosinophils, or basophil. Pag sinabing 5-part differential ang machine, kayang i-identify ni machine yung mga granulocytes. Therefore, magbibigay siya ng value ng neutrophil, eosinophils, basophils, lymphocytes, and monocytes. Okay, so pag 3-part differential, kailangan sa protocol, magpe-perform ng blood smear, magko-conduct ng WBC differential count. Pag 5-part differential, identifiable yung granulocytes, gumagawa lang ng smear for confirmation. Kunyari, may flaggings, i-check mo yung smear. Kung same ba yung smear sa result na pinapakita ng machine. Ito, never ko pang na-experience to, 6-part differential. Si 6-part differential, meron siyang function ng 5-part differential, and additionally, kaya niyang bilangin yung mga nucleated RBCs. Okay? I know you are tired, pero again, tinaasan po ng board exam ang RBC automation. So marami silang tanong sa automation. So kailangan nyo aralin to. What are the errors in electrical impedance? Kapag may giant platelets, syempre giant yung platelets, mako-confuse si machine. Bibilangin niya ngayon si RBC and WBC. Tataasan niya ngayon yung bilang ng WBC and RBC. Si giant platelets, i-assume ng machine na RBC, WBC. So may false increase of RBC and WBC. Pag may fragments of WBC, ganun din, tataas ang RBC, pati platelets. False increase of RBC and false increase of platelet. Kapag merong abnormal RBC, di ba ang RBC may mga inclusions din siya. Heinz, Body, Sowell, Jolly, Pappenheimer's, basophilic. Aakalain yon ng machine na nucleus and granules ng WBC. So tataas din ngayon yung WBC, falsely increase of WBC. At saka bakit? Kasi itong mga abnormal RBCs, they will resist lysis. Di ba, bago bilangin ang RBC, bago bilangin ang WBC, sisirain mo na yung RBC to avoid interference. Hindi nasira yung RBC. So ika-count siya ng machine as WBC. I think this is last part ng automation. Aside sa electrical impedance, meron tayong tinatawag na optical scatter or light scattering. So, si optical scatter, gumagamit siya ng optical light. Ang tatandaan nyo lang dito, si optical light, minimeasure niya yung size ng cell and yung complexity ng cell. Ano yung complexity ng cell? Ang RBC, hindi siya considered na complex cell kasi isa lang siyang bilog, wala siyang nucleus, wala siyang anything. Ang kino-consider na complex cell are the WBCs. Kasi complex yung morphological structure nila, meron silang nucleus, meron silang granules. So sa optical light, minimeasure ang size, minimeasure ang complexity. Iba to ha, ibang principle. So ang RBC automation, kung hindi impedance counting, optical scatter ang ginagamit na principle. Iba-iba yan per machine. So you can check your machine. If gusto ninyong magmagaling sa stuff ninyo, itanong ninyo, ano po ba yung machine na yan? 3-part, 5-part, 6-part? Ano po yung principle? Impedance po ba or optical? But I bet hindi rin nila alam. Kasi maski naman ako, kung medtech ako, hindi ko na pakikialaman yan. But actually, sa ibang bansa, if gusto nyong mag-take ng ASCPI, applicable tong mga principle na to. So sa optical light, nagkakaroon ng light scatter. Yung light scatter, tandaan nyo na lang, may tinatawag na forward scatter. Forward scatter, side scatter of 10 degrees and 90 degree scatter. Si forward scatter, it determines the cell size. Si side scatter, it determines the internal complexity. Si 90 degree scatter, ito yung cytoplasmic granularity. So yan na, sa forward scatter, doon nakikita yung cell size. Sa side scatter, nandun yung internal complexity. 90 degree scatter, nandun yung cytoplasmic granularity. This optical scatter is used for WBC differential. Okay? So there are machines na for counting electrical impedance ang principle. Pero to determine the WBC differential count, ang ginagamit nilang method is light scatter or optical method. So itong dalawang principle na to pwede itong mag-exist sa isang machine or yung isang machine, isa lang yung ginagamit na principle. Iba-iba. So ito si RBC histogram. Si RBC histogram, so again, sa internship niyo, tignan niyo yung machine niyo, magre-release siya ng RBC histogram. Applicable to sa anemia. So sa RBC histogram, pinapakita niya yung size distribution of different cell population, different RBC population. Kaya nga RBC histogram. Yung nakikita sa x-axis is cell size, yung nakikita sa y-axis is cell frequency. Two parameters involved, MCV and RDW. So kapag macrocytic, nagkakaroon ng shift to the right. Shift to the right kapag macrocytic ang cells. Ibig sabihin, mataas ang MCV. So ito yung color green. Kapag shift to the left, microcytic ang RBCs, ibig sabihin, mababa ang MCV. Pag sinabing bimodal curve, presence of two RBC population. For example, sa blood transfusion, merong normocytic na cell, merong microcytic na cell. For example, si patient suffering from let's say thalassemia. So sa thalassemia, microcytic ang RBC. Specifically, beta thalassemia. So sa beta thalassemia, microcytic ang RBC. Di ba transfusion dependent ang beta thalassemia? So sasalinan siya ng dugo coming from a donor na merong normocytic cell. So sa bimodal curve, merong two cell population, normocytic microcytic or normocytic macrocytic. Yan yung itsura sa RBC histogram. Siyempre, isa lang yung i-display ng curve. Yung black, yun yung normal curve. Okay? Next, we have cytochemistry. Wala na akong i-add masyado dito. It is as is. So sa phosphatases, we have ACP. Sa ACP, ang result nito is dark red granules. So ginagamit ang acid phosphatase for acute T-cell lymphocytic leukemia. Kasi ang B-cell, walang acid phosphatase. Next, LAP or leukocyte alkaline phosphatase. So as mentioned earlier, ito yung ginagamit to differentiate chronic myelogenous leukemia from leukemioid reaction. So ito yung mga increased LAP score, ito yung mga decreased LAP score. Next, we have the esterases. So kanina, we have mentioned ang esterases, ginagamit siya for granulocytes and monocytes specifically. So we have specific esterases and non-specific esterases. So we have, naputol na naman, naphthol ASD chloroacetate esterase. Again, si chloroacetate is specific esterase, so it is used to rule in monocytic leukemia kasi strongly positive si monocyte sa chloroacetate. Kaya ko binalikan mo. Sabi ko, si chloroacetate for granulocytic series. Wait lang. Yan, tama. Mali ako ng basa. Diba sabi ko kanina, so we have three types of esterase, acetate, butyrate, chloroacetate. Si chloroacetate, specific esterase siya kasi it is used to rule in myeloid leukemia from monocytic. So ibig sabihin, this is for granulocytes. So kapag monocytic ang cells, negative or weakly positive, pero kapag myeloid ang cells, positive. So myeloid cells, positive. Result, red cell granulation. Next, alpha-naphthyl acetate esterase. So yun na nga, non-specific ang acetate and butyrate. So strongly positive, C, monocytic cells, monocytic cells. Next, we have myeloperoxidase. This is the stain of choice for our rods, kaya siya ginagamit for Fab classification. So ang MPO is present in the primary granules of granulocytes, lesser extent ng monocytes, walang MPO ang lymphocytes, kaya ginagamit ang MPO to differentiate lymphocytic leukemia from myeloid leukemia. Yung other details, yan, basahin nyo na lang. We have periodic acid shift, aids in the diagnosis of acute lymphocytic leukemia, L1, L2, L3, and M6. So pag sinabing M6, erythroblastic. Then we have Sudan black B. So ang mga Sudan stain, these are stain used for fat cells. So si Sudan black B ginagamit to demonstrate lipids present in the cells, useful in distinguishing AML from ALL. Pag myeloid cells, positive. Pag lymphoid cells, negative. Russian blue stain, so ginagamit to stain the iron present in mature and immature RBC. So next, we have hemocytometry. Sa hemocytometry, so we have improved Neubauer. Ito yung itsura ng improved Neubauer. I hope nagawa niyo siya during your 3rd year. So ang chamber, meron siyang, ang area niya is 3 times 3 millimeter divided into 9 squares. Sa 9 squares na yon, yung 4 corner large squares, ginagamit for WBC count. Sa central square, yung central square subdivided into 25 squares, yun yung ginagamit for RBC count. The depth of cover glass and platform is 0.1 millimeter. Bakit kailangan ito i-discuss? Kasi ang formula ng Neubauer is ito yung manual counting of cells, di ba? Cells counted times dilution factor divided by the area and depth. So assuming we are performing WBC, example lang to ha, WBC count. Ang nabilang na cells ay 180. So ang dilution factor is 20. For WBC count, ang mostly na ginagamit na dilution factor is 20. Ang area na ginagamit mostly is 4. And then ang depth is 0.1. So if i-apply yung formula, 3,600 divided by 0.4. So ang WBC count is 9,000 microliters or 9.0 times 10 to the 9 per liter. These are the differences of RBC and WBC pipette and method. Pag RBC pipette, ang marking niya is 0.5, 1, 101. Kapag WBC count, ang marking niya 0.5, 1, and then 11. Yung color ng beads, magkaiba din. For RBC, red. For WBC, white. Volume, for RBC 100, WBC 10. Diluting fluid. Etong DF na to, diluting fluid. For RBC, ang ginagamit is saline or daisies. Sa WBC, ang ginagamit na diluting fluid is 1% ammonium oxalate acetic acid, yung iba gumagamit ng hydrochloric acid. Ang function nitong mga to, itong diluting fluid ng WBC, is to lyse RBC. Kasi mahirap bilangin if nandyan yung RBC. So sa WBC, ang diluting fluid niya, it contains components that would destroy the RBC. Dilution factor for RBC is 1:100. For WBC, 1:20 or 1:100. Area, 0.2. For WBC, kapag ito yung dilution na ginamit, ito yung area. Kapag ito yung dilution na ginamit, ito rin yung area. Okay. Meron pa ba? Ito last na. Last na kasi importante dito. We have WBC naman. WBC differential count. Sa WBC differential count, we have relative count, yun yung tinatawag na absolute count. Yung relative count, yun yung as is. Ito yung number of specific WBC type per 100 WBCs. Si relative count, ito yung actual na WBC differential count. So for example, Ano yung percent ng neutrophil? 50 to 70. Ano yung percent ng lymphocyte? 25 to 33. Ito yung actual na result ninyo sa differential counting. Yun yung relative count. It reflects the number of specific WBC type per 100 WBCs. Ang pinagkaiba, si absolute count. Kung definition ng pag-uusapan, si absolute count is the number of specific WBC type per 1 WBC type per cubic millimeter of blood. Si absolute count, ang formula nito is relative count times, i-multiply siya sa WBC count. So that would be the absolute count in cubic millimeter. For example, ang relative count, ang neutrophil, for example lang ha, 51 to 67% ang reference range. Sa absolute count, pag sinabing absolute neutrophilic count, ang reference range niya is 1,600 microliters up to 7,200 microliters. So for example, ang nabilang ninyo sa differential count is, ang neutrophil is, let's say, 61%. Yan na yung relative count. Pag tinanong, ano yung absolute neutrophil count? Absolute neutrophil count, ito times natin, 61 times, let's say, ang WBC is 4.3. 4.3. (4.3) 61 times 4.3. Or gamitin natin yung microliters kasi cubic millimeter yung sinasabi dito. So let's say 4,300 per cubic millimeter. 61 times 4,300. 0.61 times 4,300. Okay. So i-apply natin relative count. So percent. 61% is 0.61 times, ano yung WBC count natin? 4,300. So ang result na nakuha natin, ang absolute neutrophil count is equals to relative count 0.61 times 4,300. So ang result is 2,623 per microliters. So ito yung absolute neutrophilic count. Again ha, yung relative count, yan yung actual differential count. Pag absolute neutrophilic count, ginagamit natin yung WBC count as a factor. Isusulat ko na lang yung normal value ng iba. NEBLM. Si eosinophils, 45 to 440. Si basophils, 45 to 110. Si lymphocytes, 960 to 400. 4,400. Iba-iba to per hospital, pero ito yung book-based. Si monocyte, 180 to 880. Lahat ng yan per microliters. So baka kasi matanong sa exam. So yun lang, that would be the end of our discussion. So 3:48, you still have time to rest prior to your pre-lecture exam na sinesearch nyo din naman ang sagot.